work on second look procedure for chronic otitis media with cholesteatoma in our hospital. And so when we the objective of treatment of cholesteatoma is surgery to eradicate the disease and preserve or restore the hearing. And the surgical approach was divided in a canal up and canal down procedure. And in the past, we do lots of canal down procedure, but we have a large cavity with persistent or arterial. So now we do more and more canal up procedure, with, but we let higher rate of residual cholesteatoma and recurrent also. So we, for some cases, we have to do second look procedure with the two purpose to explore if there is any residual cholesteatoma and to do osteoplasty if necessary. And our work is to evaluate the outcome of second look procedure for treatment of chronic otitis media with cholesteatoma. So when we do surgery for cholesteatoma, we count on this element to decide if we do canal up or down. When we do canal up, when the cholesteatoma is localized and the muscle is minoritized and the usually is functional, and we prefer to do it especially in children, and when we can follow up the patient agree to for the second look, and otherwise we do canal down surgery. And our work in our department, when we do surgery, the primary surgery for cholesteatoma, when we plan for the second stage, if the cholesteatoma is advanced and spread to many locations, and we cannot remove and block. And so we set up for the second stage after 1 year. And otherwise, if we can remove and block cholesteatoma, and cholesteatoma is more localized, we follow up with diffusion-wasted MRI, and if there is any suspicion, we do second stage, and then we analyze the result. And so in our study, we have 30 patients with cholesteatoma, and we do kind of up for primary surgery and secondary surgery from 2018 to 2024. And this inclusion criteria, we select the patient with conductive or hearing loss, and then we do surgery, and during surgery we do canal technique with enteroarticulotomy to remove cholesteatoma from posterior to anterior, and sometimes we have to do facial recess to control the disease in the facial recess and sinus tympani in this area, and we keep intact the posterior canal wall. And for the cholesteatoma in the attic, we do articulotomy to drill and to remove all the cholesteatoma in the attic, and after that we reconstruct the attic wall with cartilage at this level. So if we can remove the cholesteatoma with, we usually work with a microscope, but we combine with endoscope, to angle endoscope, to be able to remove the cholesteatoma without drill more the attic wall, or even we can control with 30-degree endoscope, we can control the entrum, or even entrum at this level with the endoscope and angle instrument. And so we can avoid opening the drilling the muscle. So during the surgery here, you can see the lateral cervical canal and the entrum, so we can control the cholesteatoma, and even we use endoscope to control the disease in the foot plate stay peaceful breath at this level, or even sinus deeply. So we at this primary surgery, if possible, we do osteoplasty, which here is in constant position, or we use also double block cartilage to put within the same structure to the typical membrane. And what we do so for the second stage, we look for the residual cholesteatoma, and we use also angle endoscope to check for residual and cholesteatoma. And the second work at the second stage, we look for the mobility of the prosthesis. Sometimes we have a fibrous tissue around the prosthesis, so we have to liberate from the prosthesis, and sometimes we have to reposition the prosthesis because it's not in the right position. And how about the result? Outside we have 30 patients, and the time between two surgery is about one year. We do in the first surgery tympanotomy with tympanoplasty, and kind of up tympanomastectomy with tympanoplasty, and for some cases we have to do posterior tympanotomy. And we found cholesteatoma mostly in the artery, facial recess, and sinus tympani. And we do osteoplasty at the primary surgery for 80%, and including partial and total osteoplasty. And in Vietnam, we don't have enough money for artificial prosthesis, so we have used a lot of autonomous prosthesis like head balance for the incurs or tragal cartilage or mastoid cortical. And after the primary surgery, the tympanic membrane is perforated. In one case is other up close, but where some retraction occurred due to the function of the eustachian tube. And for the second surgery, we reopen the mid-ear, the mastoid, and we check for the residual cholesteatoma, and we do tympanoplasty if necessary, especially for retraction of kidney and osteoplasty also. And we found that in our surgery there are 40% of residual cholesteatoma and 3% recurrent cholesteatoma. So we remove it, and we do also we check for the situation of the prosthesis. So the prosthesis is in good position and good mobility, 30%, but some prosthesis is limited mobility or in wrong position. So we fix it with our osteoplasty, and we liberate the adhesion around prosthesis around the prosthesis. And then at the end of second look, we have 100% closed tympanic membrane and less arteriostatic tympanic membrane. Like in this case, I do redo the tympanoplasty with cartilage to fix the rejection complete. So how about the hearing result? Before primary surgery, the PTA average is 45 and A1 gap is 32. But after primary surgery, we decreased the PTA from 45 to 37, and A1 gap from 35 to 27. And here is after second surgery, PTA and A1 gap decreased a little bit, and here is the comparison between before primary surgery and after primary and after secondary surgery. And so it's the same with A1 gap. We decreased the A1 gap from 34 to 27 and 25 after 2 times of surgery, and the percentage of A1 gap more than 30 dB is decreased. For conclusion, we do two-stage surgery for advanced cholesteatoma of the middle ear, and we do osteoplasty for 80% of the primary surgery, and the other we do at the secondary surgery with 100% autologous material, and we found that residual cholesteatoma at the second look is 40%. 3% is recurrent cholesteatoma, and we can close the tympanic membrane in 100%, and the PTA decreased from 45 to 38, and aggregate decreased from 34 to 25. And so in our country, we use a lot of autologous procedure, and sometimes we do osteoplasty at the primary surgery, and we have a reasonable result in the Vietnam condition. So thank you for your attention.